Thank you, Dr. Carr, for the introduction. Hi, everyone. My name is Salmia. I just graduated from medical school here at the University of Buffalo, so I'm going to be a rising IM PGY1 at Montefiore in New York City. So today I'm going to talk about otoscopy and common ear diseases and problems. And special thanks again to Dr. Carr for helping me put this talk together, and our facilitators, Nicole, Christina, and Lauren, for really putting this all together, this whole talk and series. So here are some of the learning objectives. I'm kind of going to break it up into two different parts. First, I'll talk about the otoscope exam and the different components of it and why it's important. And then we'll move on to ear diseases and different problems. Okay. So first of all, why is otoscopy important? Just as we examine the external ear for scars, wounds, signs of inflammation, or really anything else that could be going wrong with the ear, we also need to assess the health of the rest of the ear, including the middle ear. And the best way to do this is by using an otoscope. So here we have a closed otoscope, closed head, and an open head otoscope with these detachable speculums. They come in different sizes, and we want to use the biggest one that could possibly fit in our patient's ear in order to see the best with most of the light getting in. So I do have a quick video on how we do this. I'll just play that very quickly. So that's just kind of a quick overview of how, sorry, this is gonna play again. Let's see if we can move past that, of what exactly we're trying to look for. So we can kind of break down the otoscope exam into three different parts. First, you're looking at the external auditory canal. Then you'll also want to see the tympanic membrane or the eardrum and the middle ear. And then the last part is to look at to do pneumatic otoscopy. And the reason why we do that is we want to determine the mobility of the tympanic membrane. Normally it should be mobile, but if it's not, then that could be an issue of some type of disease process going on. And the way that we do that is with a closed head otoscope. If we have this insufflation bulb on here, then you kind of release a little puff of air into the ear. And it can be a little bit subtle to see here, but you can see there's a little bit of movement. It happens a few times. So you can see that a couple times it moves back and forth with the puff of air. So now let's take a look at a healthy ear. What's going on here? What can you see? Feel free to put anything in the chat or just speak up.
It's really red.
Mm-hmm. Can you see the eardrum?
No.
No, and why is that? What's in the way?
There's cerumen.
Yep, exactly. So we have all of the cerumen or earwax in the way, and this is considered cerumen impaction. This obviously makes it impossible to see the tympanic membrane and really look at the middle ear. So you have to remove the earwax either by irrigation, manual removal, or cerumenolytic agents like hydrogen peroxide. So now that we have removed the cerumen, let's look inside the canal. There are a couple of questions that you want to ask yourself to kind of write down in your note if you're writing this down for the physical exam. Are there any foreign bodies present or that earwax that we removed? You want to describe the color of the tympanic membrane. Does anyone want to give it a shot of how you would normally describe a normal tympanic membrane? It's okay if you don't. So this would be considered a pearly gray translucent membrane. So normally you want to be able to see slightly through it to some of the structures in the middle ear, and there shouldn't be any perforations there. You also want to determine if it's bulging or retracted in appearance, or if it's just kind of taut and normal. This is taut. If it's bulging, then it would be coming out towards us, towards the screen. And if it's retracted, it would be kind of pushed against the middle ear structures. And then you also want to see if there's any fluid behind the ear. Or behind the tympanic membrane. In this case, there isn't any, and that's normal. Now, before I kind of go off explaining the different type of eardrum structures and landmarks, does anyone want to try explaining or pointing out any structures they see, like this or that? And I don't expect anyone to actually know any yet, so I'll talk about it if you don't.
Got the stapes?
The stapes is a little further back, so not quite, but you're on the right track.
The head of the malleus.
Yes, you can see the malleus over here. Anything else?
You can also see the pars tensa and the pars flaccida.
Yeah, exactly. So all of this part over here is the pars tensa, pars flaccida is over here. And David, I see you're talking about the cone of light. That's correct, coming off right over here. Okay, so let's actually go over all of them. Yes, and the umbo right there. So over here, I have both of the ears kind of placed side by side. If we're looking at the right ear, just like we were describing before, the umbo is the part of the malleus that forms the center of the eardrum, and it's attached to this manubrium or long process, long handle of the malleus. And that's the first of those three ossicles that's closest to us to visualize. A little bit further behind it, you can sometimes see the long process of the incus, which is second. The stapes is usually a little too far back to see it. In terms of the tympanic membrane itself, above the long handle of the malleus, you would see the pars flaccida, where it's not as taut compared to the pars tensa all around it. And then there's the annular ligament, which surrounds and keeps the tympanic membrane in place. And just as was mentioned before, you have the light reflex coming off of the light source from your otoscope. It's also called the cone of light. Okay. And then we also want to be able to describe which ear we're looking at in case we don't remember which ear we looked at initially and we just have a picture to go off of. And a really easy way to do this is by doing the eardrum quadrants. So when you have the handle of the malleus, the way that I like to divide up the eardrum into quadrants is by taking the plane of that malleus and dividing it, so then there's the front half and then there's the back half. With the anterior half, you have the cone of light, so that kind of serves as your marker of also knowing this is anterior. And behind this plane, you have posterior. So if you were to take the handle of the malleus and kind of going along the cone of light to form this quarter pi piece of the right tympanic, or of the tympanic membrane, you see which side of the full tympanic membrane that's on, and that tells you which ear you're looking at. So in this case, if you have the handle of the malleus and the cone of light forming this anterior superior quadrant, it's on the right-hand side, so this is the right tympanic membrane. And you do the same exact thing with the left side. You find the anterior superior quadrant formed by these two landmarks, and since it's on the left side, it's the left tympanic membrane. And usually this is useful for when you need to specify the location of a perforation, retraction pocket, scarring, or really any other symptoms. So going back to our healthy ear, can anyone try telling me which ear we're looking at?
Left?
Mm-hmm. And why do you think that?
Where the cone of light is for the anterior portion of the ear.
Nice job. So now let's just run through each of these numbers and feel free to put it in the chat, starting with number 1. What is that?
The manubrium
of the malleus.
Mm-hmm. How about number 2? That's pointing along the entire outside.
of the annulus.
Mm-hmm. How about number 3?
Cone of light.
Correct. How about 4? It's pretty much this entire part of the tympanic membrane.
Pars tensa.
How about number 5?
Pars flaccida.
Correct. How about 6? It's a little bit harder and more subtle to see.
Incus.
Mm-hmm. And specifically, it's the long process of the incus. And how about number 7?
Umbo.
Yep. And number 8? It's so long here, surrounding it. So that's the external auditory canal. So don't forget to look at the canal too. That's part of the exam, and you want to make sure you're not missing anything out there. And just kind of a bonus question, it's difficult to see, but can anyone make out what this structure is kind of slithering along here? Hint, it's a small nerve.
Chorda tympani.
Chorda.
Yep, it's the chorda tympani, and it runs between the ossicles. So sometimes you can see that. And then you can also see the promontory of the cochlea and the round window right behind it. Those can be difficult to see though. Okay, so now we're gonna try and hit a bunch of different ear diseases and problems. I'll show a slide of one of the ears or what you're seeing in the otoscope in a case, and then I'm just gonna ask you questions about that. So case one, a 1-year-old patient is brought to the ED with a 5-day history of irritability, and her father says she's been tugging at her ear constantly over the past few days. She has a low-grade fever. Her father mentions that several family members living with the patient have had a cold within the past week. So I know I started off with a pretty difficult one, but can anyone tell me which ear we're looking at, right or left?
Right ear.
Yep, you can kind of see the malleus over here in the umbo. So this is going to be the anterior superior quadrant. And what else do you see? Just in general.
The tympanic membrane is like bulging out.
Mm-hmm. And would you say that it's pearly gray translucent or not?
It's like inflamed, irritated.
Mm-hmm. Correct. And is it retracted, bulging, or taut as it's normally supposed to be?
Bulging.
Yes. Any guesses on what this patient might have?
Otitis Media.
Correct. So this is acute otitis media. And here, I'll just pause this. And what it is an infection of fluid that accumulates in the middle of the ear. And this is an acute episode because it's been less than 3 weeks in this patient. It's very common in children. It's actually the second most common pediatric diagnosis in the ED right after upper respiratory infections. And the most common pathogens are strep pneumoniae, followed by Haemophilus and Moraxella. So the symptoms can be pretty nonspecific. There's otalgia, which in children can present as irritability and pulling or tugging at the ears. And then there's also autouria, low-grade fever, vomiting, diarrhea, poor sleep, and feeding. And in order to diagnose this, you need to do pneumatic otoscopy or tympanometry. So this video, it starts off showing a normal pneumatic otoscopy exam. So you can see how mobile it is in comparison to AOM, where it's not moving nearly as much. So this is a good visual representation of what you would see for AOM. And going back to that picture, so a bulging tympanic membrane is the most specific finding in AOM, and combined with the fact that it's opaque, this is highly predictive of the diagnosis. It's also immobile or less mobile than usual, and you may not always see the fluid in the middle ear space because of how opaque the membrane is. And erythema is non-specific as a finding, but oftentimes you would see it. In terms of management, I do want to first say that if a patient has minimal symptoms, then sometimes they can be observed for a day or two just for seeing if they spontaneously recover, and up to 60 to 80% of patients do. But it's controversial to wait that long because if the infection does not improve, then complications can be very serious, including facial paralysis, meningitis, abscess, etc. But if you are doing first-line treatment, which you should, then oral antibiotics are key. And you would start off with high dose amoxicillin, a 7 to 10-day course usually. But if the patient has taken amoxicillin in the past 30 days, you would use amoxicillin clavulanate instead, or also if there's no improvement after 72 hours of amoxicillin treatment. And you would also do pain control. But if there is no improvement, then you can consider an IM or an IV ceftriaxone. That also works if a patient is vomiting and cannot tolerate oral medications, along with clindamycin. And if it's recurrent AOM, which is at least 3 episodes in 6 months, or at least 4 episodes in 12 months, then you can put in a tympanoscopy tube for ventilation of the middle ear space. Going on to the next case, it's a bit difficult, but the tympanogram might help out with this one. So case 2, a 29-year-old patient presents to clinic with difficulty hearing out of one ear. He describes also having a sensation of his ear popping and fullness. He has a history of recurrent URIs. So first off, can anyone figure out which ear we're looking at?
Right ear.
Yep, this is the right ear. And what looks weird about it?
Meniscus, middle ear effusion.
Mm-hmm. You're right. So this is actually also the diagnosis of otitis media with effusion, because we can see this straw-colored, thin, watery exudate in the middle ear space, and it has these hair fluid levels or bubbles right there. And it matches up with this tympanogram. I know we talked about audiograms and tympanograms a couple of weeks back. Does anyone know what type this is?
Type B.
This is type B. So otitis media with effusion, it's the presence of effusion in the middle ear without signs of acute inflammation or infection, and that's important to know. It's the most common complication of otitis media, and it may also be due to eustachian tube dysfunction, or ETD. And it commonly occurs at the same time as upper respiratory infections. Hearing loss is actually the most common complaint, along with oral fullness. That's also very common. And it shows this flat type B tympanogram. And any adult with a unilateral persistent otitis media with effusion should be evaluated for nasopharyngeal carcinoma that could be causing the ETD. And going back to that picture, we have that tympanic membrane not bulging or erythematous like an AOM. So that's a way to distinguish between the two conditions. And it's neutral or retracted in position. We can even see a retraction pocket and an air bubble in this case. It may be opacified with loss of light reflex, so it's definitely a little bit hidden there. And there's also decreased mobility. For its management, usually resolves spontaneously with watchful waiting. You wait about 3 months, but if it's present for longer than that, you want to place a TIMP tube to facilitate the air entry into the ear space and to prevent fluid reaccumulation. And if there is formation of a retraction pocket, you would consider a tympanoplasty. And because because bacterial infections are not the cause of this, you don't have infection or inflammation, antibiotics are not recommended. Okay, so case number 3. A 32-year-old male presents to clinic with slight pain and loss of hearing from one ear. He states that this began while he was at work yesterday as a construction worker, during which there was an explosive blast at his work site. When he woke up this morning, he noticed a drop of blood on his pillowcase from his ear. So which ear are we looking at?
Left ear.
Yeah, this is the left ear. And what do we see that's abnormal?
He has a perf.
Yeah, would you be able to describe which quadrant we see this perf?
It's like in the left lower quadrant.
So if this is these are the approximate kind of boundaries of the anterior superior quadrant, which one would this be below it?
Anterior inferior.
Nice job. So yeah, this is a perforation. It may be caused by direct trauma, infection, pressure changes, a tumor, and you see symptoms like hauturia that may be bloody, like in this patient's case, otalgia, tinnitus, or hearing loss. And you can see that it can vary in size from pretty small to a little bit larger to a really large one. You can see that cochlear promontory very clearly along with the stapes and incus. So this is a pretty bad perforation in the bottom corner. Most cases do resolve spontaneously. You could just throw some pain control at it, some Tylenol, and you want to keep the affected ear dry to prevent having that damp environment for infections. But if spontaneous healing is unlikely, you could do surgery like a tympanoplasty. So some studies have even shown that if you directly apply FGF, then it can be very effective for healing a large tympanic membrane perforation. Here is what it looks like to begin with. And after 2 months of treatment, it has completely healed. So that's another cool thing to know about. Okay, moving on to the next case. A 2-year-old child is brought by her mother for a month-long history of ear drainage from this ear. Aside from this, she reports no other signs or symptoms. So again, that's a month-long history. First off, which ear are we looking at?
Left.
Yep, that's the left ear. And what do you see? What looks a little bit different about this ear?
It looks like there's a perforation and also some pus that's draining.
Yeah, exactly. So you see a pretty large perforation here, and through that there's this mucopurulent discharge. Any guesses on what this patient might have? If not, that's okay. We'll move on to the next slide. So it's chronic suppurative otitis media. It's also sometimes called just chronic otitis media, but in this case, it's a chronic infection of the middle ear without an intact tympanic membrane. So that's key. There is a perforation present. And it may be a complication of either untreated AOM or a chronic effusion. It's often polymicrobial. So even though Staph aureus is the most common pathogen, there can also be Pseudomonas, Proteus, Klebsiella, and different anaerobes. Classically, it presents with 2 to 6 weeks of chronic or persistent autourea, and it may or may not have acquired hearing loss, tinnitus, and oral fullness. So when you're managing this, you want to rule out a cholesteatoma because it can look a little bit similar with its color. And you want to culture the ear discharge to guide the antimicrobial therapy. Oftentimes you use topical quinolones like ofloxacin drops. And then here again, we can see that perforation and the mucopurulent discharge pointed out. So this is the next case. A 74-year-old patient presents to clinic for otalgia. She's hard of hearing and wears hearing aids, but she's currently unable to wear them because of exquisite tenderness and pain when she touches her ear and tries to put them in. Her medical history shows that she has poorly controlled diabetes. So what do we see here?
Her external auditory canal is really inflamed, so much so that you can't really even see the TM.
Exactly. So what are we guessing this probably is?
Otitis externa.
This is otitis externa. It's also commonly called swimmer's ear, and it's an infection or inflammation of the external auditory canal. Risk factors include high humidity, temperature, water exposure, so it's often seen in swimmers, local trauma to the canal, hearing aid use, and history of diabetes mellitus. Classically, there is otalgia, especially as they move their pinna and trying to put in something like earplugs or the hearing aid. It starts off with pleuritis usually, and there can possibly be autourea and oral fullness. And then there is also severe sequelae of this called necrotizing otitis externa. It used to be called malignant, but that's kind of a misnomer. And this occurs due to invasive infection of the EAC and the skull base. So you have to consider this if there's refractory otitis externa, if they have a fever over 102.2 degrees, if they have diabetes or immunosuppression. And oftentimes Pseudomonas is the cause. So here we have edema of the EAC in both cases. You can see some erythema, and we may have thick autourea with or without malodor. You can kind of see some granulation tissue over here. If you have to guess, which of these two ear canals looks more like necrotizing otitis externa?
Bottom right.
Bottom right one, that's correct. And the management, if it's uncomplicated, you want to clear the EAC, you want to give some topical antimicrobials and pain control because it is painful. If it is necrotizing, you want to do cultures and determine what is the best long-term antibiotic. Often it's anti-pseudomonal like fluoroquinolones. You also want to assess cranial nerves for palsies from the infection spreading. And you may require surgical debridement depending on how bad it is. And looking back at your question, yes, you would need to rule out a cholesteatoma with a CT because that can also eat away and it can erode pretty quickly. Okay, so next case. A 10-year-old boy is brought to clinic for evaluation of his hearing. He feels fine, but his mother is concerned that he sometimes has trouble hearing others both at home and at school. So you look into his ear. First off, which ear is this?
Is that the right ear?
Yes. It's pretty difficult to see, but I'm assuming that this right here is where the malleus would be, the manubrium of the malleus. And then what do we see that looks abnormal in this ear? What is all of this over here? So all of that is kind of an accumulation of debris from keratinized squamous epithelium. And this is a cholesteatoma. So A cholesteatoma is an epidermal inclusion cyst or an accumulation of keratinized squamous epithelial debris in the middle ear or the EAC. The debris can accumulate over time and can cause erosion into surrounding tissues. And it can be classified as either acquired or congenital. I won't go into too much detail about that, but it's good to know that there are different types of them. Clinically, it has an insidious onset, and the most common early signs are conductive hearing loss and painless autouria. Congenital cholesteatomas often present asymptomatically, and they usually present in the anterior superior quadrant, like it does over here. Whereas acquired cholesteatomas, they may present with recurrent painless, malodorous autouria. And here, sometimes they have granulation tissue or polyps. We can see that the cholesteatoma is around here and here, in both cases in the anterior superior quadrant. And sometimes there are these retraction pockets in the posterior superior quadrant. And this bottom right photo shows what looks like yellow crusting and debris in the attic of the canal and on part of the TM instead. So it doesn't always look like this pearly white mass, but it can kind of erode further through and sit on top of the tympanic membrane. Management is surgery. So the type of surgery performed depends on the location of the cholesteatoma and how much involvement there is of the tympanic membrane and other structures. But usually the most commonly performed one is a tympanomastoidectomy to remove the entire cholesteatoma. Case number 7. So a 37-year-old patient comes to clinic with difficulty hearing. Of note, he had multiple sets of tympanostomy tubes placed in his childhood. He has no other complaints. First off, which ear are we looking at?
Right?
Mm-hmm. This is the right ear. And what do we see on this, in this picture?
Is that granulation tissue?
Kind of. It's similar to that. It's more of scar tissue.
It looks like tympanosclerosis to me.
Yep, you are right. So this is tympanosclerosis. It's these hyaline and calcified deposits that form on both the tympanic membrane and in the middle ear. So because it involves the ossicles, then it can limit the movement of them. Because of that, conductive hearing loss is pretty common. And scarring may be caused by grommet or the tymp tube insertion or recurrent middle ear infections. So in our patient with having multiple tympanostomy tubes for this infections, that could have predisposed to this formation. And they're often called chalk patches. And because they're forming the scar tissue within the tympanic membrane, it causes decreased mobility. So just to clarify, these are intratympanic patches of sclerosis. And it can be easily confused with another condition called meringosclerosis. The difference is that with tympanosclerosis, the deposits are on both the tympanic membrane and the middle ears, so the ossicles can be involved. Whereas with meringosclerosis, it's only the tympanic membrane. So it can be kind of difficult to see on the pictures. Sometimes it's more limited in meringosclerosis, but you also want to do an audiogram to see if there's conductive hearing loss. It's pretty common to have hearing loss in tympanosclerosis, whereas without ossicle involvement in meringosclerosis, you don't have hearing loss. So you don't have to do anything in terms of management. For tympanosclerosis, though, if there is pretty severe hearing loss, then you would want to do a tympanoplasty with or without ossicular chain reconstruction, and this can completely reverse the hearing loss because it is conductive. Now, I'm just going to briefly touch one or two other ear problems before I end, because I know I'm over time. So in this is the left ear. We can see eardrum retraction, and this is often a result of eustachian tube dysfunction. This picture is a pretty severe version of that, but the blue arrow points to the facial nerve, which is almost completely exposed. The black arrow is pointing at the stapes, which you pretty much never see when you're looking at a normal tympanic membrane. And the white arrow points at the cochlear promontory. So in this picture, the incus has actually been completely eroded. So with this, because there is negative pressure from the eustachian tube dysfunction, you see a type C tympanogram. And the way that you would treat it is usually with tympanostomy tube placement, eustachian tube dilation, laser therapy. There's all different options. And if it's very severe, then surgery may need to be done. And then this is the final condition. So hemotympanum. This is the presence of blood behind the tympanic membrane in the middle ear space. when you're looking on otoscopy, then it looks like this kind of dark red, violet color or dark blue. And it's usually the result of a basilar skull fracture. It may appear within hours of injury, so it's a pretty good kind of way to determine if someone has had a basilar skull fracture and they show up to the ED with their ears looking like that. It may also occur though from nasal packing after nasal surgery or epistaxis. It can go through and into the middle ear cavity that way. Also from bleeding disorders or using anticoagulants, and also temporal bone fractures. And the management is by treating the underlying cause. Also, these patients may present with some oral fullness or decreased hearing. So those are some signs to look out for. Here are all my references.